Welcome to a Cisco meeting. You are entering the meeting now. This meeting is being recorded. You are the only participant.
Shackelford, something about medicines. They give you a callback number or like the way that they find it. And I was like, I don't know what's that. And then I said, they're right about that name. They just changed the prescription. And I was like, something about who has each bottle has like 8 times treatment. I don't know. So I think I did put in some regular stuff, trying to like clear. It's like, I don't know how to do that 8%.
Yeah, I was like, I'm assuming that's okay. Yeah.
I hope so. That's the plan. I've asked them all to email me their presentations. So I'm applying.
Jeff when I got to her ears.
Well, I have a relative. It was like totally movable. I just like had pictures of the little car. But like open the door, like I kind of like this one. This is So I will say, well, I would say this, like, I mean, like, different people love it, but the other one has a lot of
That's what I think. Thank you for reminding me.
But the one I have, some people find very.
Yeah, otherwise I just keep going to sleep.
I don't know.
Oh,
Well, so
yeah.
you guys, yeah, so I just want to get.
Oh, yeah, no, we'll, I'm just
I
working on everything he does.
Because like,
I got it.
I got it. I wasn't paying it initially. That's when I kind of. So
except for you.
when I got, you used to have to.
But yeah, you're first.
And now it's so I was like, and then I did not, but then. Yeah, I think. But I was, Eric had established, so I don't know whether it would have been good. Yeah. But I really like my, there can be a little.
That's fine, that's just straight up.
I think it was money. Yeah, I was like, oh my gosh. That is true. I was like, he's like, it's gonna make your life better. Like, it's that money. Yeah. So, that's why. I use this over here. But you're still weird. But I also have to then I see it. So I did it. I've never posted it's an Airbnb. Like having that option. Like for 6 nights, you got like 12 or 13. But for Jackson, that's doing that. And our icon has like I would wear it like scrubber shoes. Yeah, like having breakfast and dinner, and it's like $8. But also, even if you're not you know that you go to there's like a yeah, versus like television. Like, there's we were actually in Wilson, which is right down the road, and it's just as close to this river. Park and ride to the city. So I just because I was just like, the run here is longer. Right? I mean, I still like musicians, so I was like, oh my god. Yeah, I lived there for a year. Okay, so you know, like we did the aerial thing one time, and it took like an hour, so we never did it again. Oh, that's an hour. And like as you're getting off, like expert level only. Please have your flashlights and you're just like it. And me and Jake are just like, I think we slid down like half the stuff on our side, but we got into hot chocolate and a lot. You're looking at it, you're like, so how is
All right, looks like folks are still kind of gathering and rolling in and whatnot, so we'll get started. Today we have our dress rehearsal for Academic Surgical Congress. A couple announcements. Next week, Grand Rounds, I'm really looking forward to. Dr. Steve Eubanks will be joining us, one of the kind of pioneers of the early days of laparoscopy. We'll be talking about past, present, and future of minimally invasive surgery. Next weekend is the Montana, Idaho, Wyoming, Utah chapter of the American College of Surgeons meeting at Snowbird. Just a reminder, there's an alumni reception Friday night the 24th at Primrose at Snowbird, wherever that is. I'm sure people are going to do that. Then the ABSITE little quiz coming up shortly thereafter. Academic Surgical Congress after that, and then Ski Day on February 7th at Solitude, followed by dinner and beverages of your choice at Wausau. So going over Academic Surgical Congress, everybody gets a fun trip to Disneyland. We've been here. So we've got Dr. Bagley, a 3-minute presentation. Dr. Gutnick, Dr. Zach, and Dr. Pruitt have 8-minute presentations. So basically we'll do the presentation. We'll leave about probably 3 to 5 minutes for questions, discussions. You notice typos or something, let's just try to get these things short up and looking good. So when you come up, back with Zach and Pruitt, before you start, we just quick title and whether or not you have reviewed your presentation with your mentor or not. All right? And I think we have the, or you can just stand here and use this microphone, or just project. I didn't have, I'm not known for projecting. Right.
Kevin Bagley, this is the implementation of ATLS in Mongolia. And Dr. Price and I have not gone over this one specifically, but we've gone over elements of it. Not these 5 slides. Then you're ready to go. No disclosures. Mongolia is a low middle-income country that has tremendous advances in modernization over the past 20 years. Some of the results of modernization have been population shifts, large cities, and also increasing motor vehicle traffic. With increased road traffic in cities comes trauma. Injury is now the 5th leading cause of mortality in Mongolia, dominated by motor vehicle traffic. This graph from the Center for Health Development shows morbidity and mortality related to trauma since 2008. Injury was recognized as a threat to public health by the Mongolian Ministry of Health, and in collaboration with the WHO, the trauma training was targeted as one focus for improvement within the healthcare system. Mongolian physicians requested advanced trauma life support in order to become aligned with international standards of care for the injured patient. In 2013, a partnership was initiated between the Mongolian Center for Health Development, the University of Utah Center for Global Health, the American College of Surgeons, and the Royal Australia-Asian College of Surgeons to bring formal trauma education in Mongolia to physicians in the form of ATLS. The ATLS manual was translated in 2015, and shortly after, the first class was taught. In only 4 years, workers were down to licensed formal ATLS educator. In those years, a total of 11 courses were taught in Mongolia, with 172 participants. In 2015 to 2017, only 25% of the instructors were Mongolian. Other instructors were from Australia, Southeast Asia, and the United States. These courses were taught in English and translated into Mongolian. The courses lasted 4 days. In 2018, courses were taught exclusively by Mongolian instructors. The course lasted only 2.5 days, and there were more courses taught in 2018 than there were in all of 2015 through 2017. The cumulative percentage of people who passed the course was only 30%. This will require investigation, but low pass rates can anecdotally be attributed to misunderstanding of the ATLS method, which requires reading before class, and unforeseen translational barriers such as lack of Mongolian word for essential terms such as resuscitation. This is a map demonstrating 11 provinces of the 22 that have physician exposure to ATLS. Establishing a sustainable model for ATLS in Mongolia has required international efforts with tremendous initiative from local Mongolian partners. The formal steps undertaken so far have been translation of the teaching manual, translation of didactic sessions, and likely the greatest achievement so far entirely Mongolian teaching staff. There have been 3 measured benefits to exclusively native instructors. More courses can be offered as demonstrated here. The course length has been decreased to 4 to 2.5 days, and the total cost of administering the course is reduced. The last step required to achieve independence completely is having an in-country educator that in that process around. So.
Okay. 2 minutes, 50 seconds. All right, so a couple minutes for questions, comments, constructive.
It's a lot of content in a short period of time, and you're speaking incredibly fast, and you're mumbling most of your words. I am a little bit hard of hearing as I get older, and I probably picked up about 60% of what you said. So either cut the content or slow the talk down or something. So.
Also to that at the end, like it's nice to talk from a graphic, but for your conclusion slide, especially if you have a lot of information to convey in a short time period, you could probably close with something, that's holistic that are kind of take-home messages or summary or something like that, just to give people that can't hear you or you're talking fast something to walk away with you. The other thing, can you go back to your graph about, yep, that one, forward, please? That's a little bit confusing. So if you're looking at percentages of people completing these things, I might just consider it, do it as a bar graph instead of a line. Like the x-axis kind of, it is a little hard to interpret.
Or if you did each one as a separate course.
Yeah. And you do just like you cite that there was no word for resuscitation. Maybe there were some translation issues, but that had already been fixed, right? I think it was being translated when English speakers were given the ATLS. So maybe comment on that. Does that make sense?
I'll try to find time.
Another nice kind of privilege to that, if you have a lot of stuff to say and you don't have time maybe to say it, is just do some bullet points of your key things, or some of your background demographics or things that you don't necessarily have to read through kind of line by line, but you can say, these are my demographics, or this is sort of what our representation is, and then people can take it away without you having one verbal.
anything else? Yeah.
What do you think the impact of going, potential impact of going from a 4-day to a 2-day program?
Reduce costs. It allows people to travel over longer time in Mongolia and not miss the required work time. And then if there is some sort of person has to be flown in for education purposes, I think it should be a good time.
What do you think it might be the impact of the past?
It's fine.
You got the actual number of these costs.
Was there anything about the ATLS protocol that you had to culturally change so that it would work in Mongolia?
Lots, yes. And so I haven't actually been there for a portion, so I don't, but the answer is yes.
All right, and I think the other unsaid thing is meet inventory, get this in.
Yes, sir.
All right. Okay, all right, we have 8 minutes.
Do we do my role?
Yeah, do your little spiel and.
I'm Lillian, one of the residents. I'm presenting on American Indian access to colorectal cancer screening with gastroenterologist density matter. This has been reviewed by my mentors. American Indians represent only 1.6% of the entire U.S. population. They are a minority population that are understudied and underserved. In colorectal cancer, American Indians have significantly higher incidence than non-Hispanic whites and with significant geographic and regional variations. This trend continues to be evident in other epidemiological statistical findings, and especially when considering mortality, presenting at later stage of diagnosis, and having much less screening practice or concurrence compared to non-Hispanic whites. The Indian Health Service serves 2.56 American Indians and Alaska Natives of the 5.2 million American Indians in the United States. This graph shows 12 regions across the country and their colorectal cancer screening rates. Overall, in 2018, there was only a 31.9% screening rate for the Indian Health Service beneficiaries. Of note, this data here represents all forms of screening, not just colonoscopy, but also flexible endoscopy and fecal occult blood testing. Again, as you can see, there's significant geographic regional variations. To further understand screening practices among Indian Health Service beneficiaries, Day and colleagues looked at 10 years of data and found that endoscopy was the least common screening modality, while fecal occult blood testing was the most common. Again, as you can see, there were significant geographic variations in colorectal cancer screening practices, regardless of modality. To better understand these disparities, there have been several small qualitative studies focusing on identifying barriers to screening. Common themes include lack of knowledge and awareness, taboos, cultural beliefs, concern about privacy, embarrassment, and health system barriers, access to care, long wait times, lack of transport, lack of insurance, lack of trust in the entire health system. Given these aforementioned findings, using gastroenterologists' physical locations as a proxy for colonoscopy access, we sought to examine the relationship between state-level gastroenterologist density and American Indian colorectal cancer endoscopic screening rates. Using the National Provider Identifier Registry for the year 2016, we identified all gastroenterologists and geocoded their business addresses prior to importing this into ArcGIS. Adding census data, we calculated state-level density of gastroenterologists per 1,000 American Indians. Using the CDC Behavioral Risk Factors Surveillance System Survey, we calculated endoscopic screening rates and identified other pertinent socioeconomic variables. Lastly, we performed a multivariate Poisson regression to assess the association of gastroenterologist density and endoscopic screening rates while controlling for significant socioeconomic variables. This map is representation of our study findings, which showed wide regional variation and endoscopic screening rates among American Indians and cluster distribution of gastroenterologists.
As you can see, there's not a clear correlation between number of gastroenterology providers per state and state-level screening rates. For example, Alaska and Wyoming have some of the highest screening rates and the least amount of gastroenterologists. Furthermore, you can see there's state-level geographic clustering of gastroenterologists. Looking at a state like California, the majority of the providers are located along the coast. Highlighted here are just our significant findings from the multivariate Poisson regression. Consistent with other studies, being divorced, separated, or never married were associated more likely of not getting screened, while more educational attainment was correlated with increased likelihood of getting screened. Being retired or out of work was associated with more likelihood of being screened. Lower household income correlated with less likelihood of being screened, and compared to employer-based insurance, Medicaid and Indian Health Service beneficiaries were less likely to get screened. For our main variable of interest, the number of gastroenterologists per 1,000 American Indians, we ultimately do see a threshold effect. With having more than 3.7 gastroenterologists per 1,000 Native Americans, though statistically significant, only slightly increase the likelihood of getting screened. The study is not without limitations. Our most significant one is that we use gastroenterologist location as a proxy for endoscopy access. However, we know in reality that there are other providers that provide this service. We know that general surgeons, particularly in rural areas, we know that certain primary care providers provide screening colonoscopies. Furthermore, we know that especially in rural areas, there are programs and services in place to do temporary screening camps. Secondly, we did not have actual endoscopic screening rates. We relied on a large data set, the CDC BRFSS, which patients recall what kind of screening they had, when they had it, and why they had it. So again, introducing recall bias. Furthermore, there's this data set, although being large, has a limited percentage of American Indians, although unparalleled with what is the national composition. And there's also significant risk of race classification, which is why this severely underserved minority population is always difficult to study. Lastly, although we have exact point locations for gastroenterologists, we do not know the locations of the American Indians, thus resulting in large state-level correlations and not more granular data, which would have more clinical and public health relevant results. Nonetheless, this is the first known study to attempt to better understand the relationship between physical access to endoscopy providers and the effect on colorectal screening rates at the state level and on a nationwide analysis. We found that while a minimum number of gastroenterologists has an important correlation with increasing screening rates, the effect diminishes beyond the minimum threshold of 3.7 gastroenterologists per 1,000 American Indians. Further research is required to elucidate the most critical factors contributing to these disparities. This study is a launching point for further research. We would love to do a more formal geospatial analysis to understand this relationship. This would require more granular data. We would need to know the exact locations of American Indians and their true endoscopic screening rates, probably necessitating the need for building data. Prior small qualitative studies have suggested a wide range of barriers, and we did identify significant regional variation. This would warrant further quantitative and qualitative look to better understand and design future implementation studies to address these barriers.
You can add another minute and 20 seconds to your presentation.
I spoke really fast, yeah. When I practiced it earlier,
you can add more information or slow down.
Yeah.
All right, comments, critiques?
Some of the earlier slides, your font is quite small. Probably shouldn't have anything smaller than 24 font. You look very beginning. Even on that slide, your data at the bottom. Next one, no, next one. So you get very small. You'll see that. You can't see it from a distance. So the next before that. Here, struggling to see what all those different things are. Numbers. I figure out how you get sort of see
I think the other thing on that slide is you've got B's, it looks like, next to the numbers.
Oh yeah, this was from a CD. This is not a graph I made. This is like a CBC graph, but I didn't have the subscript of the B that came with it in the graph. But
do you need a breakdown of males and females for your presentation?
no, but I think we'll double check. But again, this was not a graph I made. This was a graph from the CDC, which is the graph that they had.
So it's not like they have some.
No.
If you put something on a graph that's got a superscript next to it, the expectation is that the superscript is going to be somehow delineated on the graph.
That's fine. I can definitely play that. I can readdress that to include that for sure. And I will look again. I mean, I did spend a lot of time looking. They did separate this. They did not have one combined. I would have definitely chosen one because I agree that would have been much clearer. But I would for sure go through things again and make sure.
Another thing you could do with this graph is you could either pick males or females and say a similar pattern is seen in males or females, and just show one of the graphs and blow it up in size, and that way you'd address some of Dr. Price's concerns about the font. You go, I think it's the second slide. Yeah. What is 22 versus 15.8 and 49.5 versus 59.8?
So this was me just not explaining it well. I mean, this was trying to graphically depict mortality and screening rates, and I think I definitely spoke very fast and fumbled through this slide when I presented.
Yeah, because then I was trying to figure out those numbers, and I had no clue what any of them.
Right, so mortality is what versus what?
American Indians compared to whites.
I somehow, I had the same struggle. I was trying to.
I mean, it's like a guy with a coffin at the top, and it's like.
Right, I'm trying to figure out what the pictures mean, and I'm not even looking at the numbers or listening to what you're.
Yeah, maybe a header at the top or something.
Or could you put your sort of statements in the center, make your picture smaller? Pictures are really good. If you look down at the top. Can I ask a cultural thing? This is going to show that I'm from Eastern North Carolina, but is the right term American?
Yes.
Yes. Not Native American?
Yes, correct. That was a learning point for me as well. Okay, the formal thing is American Indian Alaska Native.
Okay.
That is what all the official government, the Indian Health Service, the CDC, the Office of Minority and Health Disparities from the state, that is the term that they use. Yes. And in all the published literature, that is the term that they use.
If you're just talking, you can use that as a term, but if you're publishing it.
You want to use American Indian?
Yeah. No, that was a learning point for me as well.
One comment from both the talks is, how do you end your talk? Kevin just stood there. You said that's it. Just have something that's very professional, how you end your talk. Thank you very much, or something that indicates what you're doing.
And especially since you had extra time, you could say in conclusion.
Yeah.
You could have a conclusion slide. If you had a minute and a half or something like that was left over, then.
Yeah, it seemed, go back to on that point, it seemed like you had a conclusion slide and then a future
directions.
Yeah, so I would maybe put the future conclusion should be conclusion, right?
Yeah.
I guess like another good, like I think that you probably already know, because I think you presented in a lot of conferences, but maybe just for people that are just starting out, like a nice sort of introduction when you walk up to the podium is just say, you know, thank you to the Academic Surgical Conference and my colleagues for the opportunity to speak, you know, and then you start. Don't forget a disclosure slide, which a lot of them mandate, most places do. And then at the end, just thank your colleagues. You know, thank your research mentor and research assistant. You don't have to list names, so that you can throw up a slide with me and something. Just say thanks again to all my colleagues that helped with this project or something. And that's a nice kind of closer filler.
So for me, I think it's way more professional. I know this is very Dr. Ivo, but I think it's much more professional to thank the moderators, know them by name and thank them by name. If I sit in a room and have to listen to everyone say, I want to thank the Academic Surgical Conference for inviting me, I want to thank my grandma, I've already said anything nice today, it makes me insane. So I prefer if you thank the moderators for introducing you. Thank you, Dr. Smith, and thank you, Dr. Jones, and then get started. And please do not repeat your title or your name, they just said it. Don't say it again.
Put your group at the end. And then another thing to Doctor's case point, it's nice to go a little early if you're going to present, and just introduce yourself to the moderators so that they know who you are. It's nice to have an opportunity for you guys. And then, having moderated things, it's also nice for me to know, like, okay, this is my next person, and they're here, and, I don't have to worry about where they are. I know how to pronounce their name, and things like that.
Can you just put up your graph that showed the percentage?
The math.
The graph. This one here. So I don't know what other people think, but when I saw colonoscopy with the blue bar, I was like, wow, that's really high. And then had to look at the y-axis and see that, oh, it's actually only 5%. I don't know. Did other people have that, or was that pretty clear to people that it's really low? Because it looks, there's a little incongruity there. I don't know that you can change the scale. Oh, this is another one.
Yeah, and I have the caption there, and when I was presenting, I said, like, Day and colleagues, and I have the reference there. This is not my graph. A publication that I took.
Could you, at the top of the blue bar, just insert a text thing that says like 6% or something, or without sloppy? I agree with Dr. Lambert.
Seemed odd to me to have figure 2 there, because obviously this is figure 2 from somewhere else. It's not figure 1 or figure 3 of your presentation.
So could you retype that in your own text?
I mean, I could
just kind of stick.
Oh, I see what you're saying. So just copy, so crop it, but copy their text, and
or just do your own text with the same.
Sure.
Do your own graph. It's super easy to create a graph. You don't need to cut and paste from this.
Yeah, you could do that, create your own graph, and then say adapted from, and then give the reference.
All right, so let's move along. Good stuff.
So I've been working with Dr. Glotzbach for the past few months, and he hasn't gotten back to me about the specific presentation, but I've been working with him for about 6 months, and we've been over all the content. So but I'm just waiting on him to get a second to review it.
So he was sent the presentation but has not reviewed it?
Yes, sir.
When was he sent?
Oh, yeah. But it's okay.
Ready?
All right. So acute thoracic aortic dissections are a fatal complication of thoracic aneurysms. They've had pre-hospital and both emergent perioperative mortality rates. But the issue comes with, who has these thoracic aortic aneurysms at dissection. They typically occur in young populations with a genetic predisposition. However, in contrast to a AAA, they don't have those cardiovascular risk factors like hypertension, smoking, coronary artery disease, and so they're typically a bit more difficult to pick up. And you can think of thoracic aortic aneurysm and dissection in 2 different categories, of syndromic and non-syndromic. Syndromic, I feel like we're more familiar with. That's the Marfan syndrome and other related syndromes. And they have known genetic factors, a lot of times a single gene associated, and they also have associated clinical characteristics. And so when these patients tend to present with maybe something associated with the syndrome, like their connective tissue disorders and whatnot, they prompt an investigation into the syndrome itself and look at the aorta versus a non-syndromic patient who, these folks have lack of extra-aortic signs, lack of the connective tissue defects. And again, those cardiovascular risk factors are absent. And so 80% of these non-syndromic patients also do not have an identified genetic variant to test
And non-syndromic cases account for about 95% of the hereditary thoracic aortic disease, and 5% come from the Marfan and other syndromes. And a lot of this is due to the natural history of this disease is very poorly understood for a multitude of reasons. Most of them listed here. So multiple heritability patterns. There's been autosomal dominant, autosomal recessive, X-linked just across the board in many different studies. There's varying phenotypic expression. So folks, there hasn't been any correlation between aneurysm, diameter, and when dissection will occur. No correlation between age or time to dissection event. And then there are numerous genes that have been identified, up to 20 genes, but like I said, 80% of these cases don't have an associated gene in the pathogenesis of their disease. There's also sporadic versus sporadic and familial cases. Sporadic being that's the only member affected versus familial, which there's more than one relative affected, but sporadic cases at this point in the research tend to make up the majority of these cases. And again, probably the most important reason that we have a difficulty with identifying these patients is that there's just lack of the risk factors and characteristics associated. And so the importance of this research is that dissections can largely be prevented with screening. We just have to figure out who to target to screen and intervene on. And a lot of the guidelines, or really all of the guidelines for this nowadays, are sort of generalized from the syndromic population to the non-syndromic. They're very, very limited. So our objective for this project was to stratify familial risk of non-syndromic thoracic aortic aneurysm and dissection to help guide a targeted and preventative care plan. So our methods, we used a case control study, the Utah Population Database, and queried ICD-10 codes to identify individuals who carried a diagnosis of thoracic aortic dissection or thoracic aortic aneurysm. And the beauty of this database is it's so large, and they already have the pedigrees put together, which is great, and we were able to identify first and second degree relatives of each of these individuals, as well as first cousins. And we had a very large control group. We matched two for age, sex, and ethnicity. And then use of proportional hazards regression analysis to identify the hazard ratios in each relative group for each aortic dissection and aortic aneurysm families. And so, first I'll talk about thoracic aortic dissection as a similar slide for aortic aneurysms. But in this group, we found that there's an increased risk in first-degree relatives, second-degree relatives, and first cousins in these dissection groups. And above is a forest plot depicting the hazard ratios. So a hazard ratio of 4.8 for first-degree relatives, and then second-degree relatives at 1.7, first cousins at 1.2. And then another thing to note about our data is that for the dissection and the aneurysm, we have very large populations that thousands, which was a lot to go through. But these are all significant. First, just being related to those with the thoracic aortic dissection essentially increases your risk of also developing a dissection. And similarly, in thoracic aortic aneurysm group, so we found that there's a significance for first and second degree relatives, increased risk for developing an aneurysm, but for first cousins was not significant in contrast to the dissection. But still, I have a ratio of 6.4 in the first degree relatives of somebody who has a thoracic aortic aneurysm. And then in conclusion, the significance of our data is that this is actually the first data to apply a quantitative assessment of familial risk and actually identify a risk group or a hazard ratio and the risk of these relatives. And we did find that a closer degree of kinship is associated with a higher risk of thoracic aortopathy, which is important in terms of the screening plans, because currently screening is supported, I guess you could say, since a lot of these guidelines that have been generalized from the syndromic, basically they just support screening first degree relatives, but our data suggests that first and second degree relatives
as well as even more distant relatives like first cousins that benefit from screening as well. And so next steps for our data will include investigating the heritability patterns, trying to get a better idea of that. And then in relation to the familial risk and compiling the two, with our goal is basically identifying who's going to benefit from targeted screening and prophylactic intervention. Okay, so I'd like to thank Dr. Gladspot and everybody else.
All right,
So that is my conclusion slide.
So you still had a minute to go. Good stuff. Being from the South and growing up in Alabama, I can, the voice inflection thing is something you got to work on.
Okay.
I know that's just kind of the way for
I'll be
a lot of
Florida.
people. Huh? Well, that's but you sound like you're asking a question all the time, and having to be more authoritative. Just to start off with.
It's beyond that. So, first of all, don't look at your slides. You look like there's a ghost over your shoulder that you're trying to talk to the entire time. And you're either looking at your slides or looking at your computer. 60% of your time you need to be looking at your audience. Second of all, use your microphone. You're standing a foot away from the microphone. And all of that is that you're too casual. I felt like you were having a conversation with me at Starbucks. This is the Academic Surgical Congress. This is the most professional meeting that you can go to. This is not Southwest Surgical. That was too casual for Southwest Surgical. Your tone, your cadence, and your staccato needs to be improved. That you are giving a very formal, very professional presentation. If you go back to your last slide, don't use periods and slides. Most of the bullet points aren't sentences. The periods look silly, especially when it's not a sentence. They're bullet points. They should be as little words as possible in them. Dr. Sadler used to always say a person cannot listen to you and read at the same time, and you want them to be listening to you. Those are only for the board person to check in and then redirect and listen to you again. So you shouldn't make them have to read your slide. They're visual aids only. You have to do your presentation. It's not professional.
Okay. In a couple weeks, I will present at the Inquirer, I think on Thursday, and so I'll make those changes and adapt.
Go back to the slide. So these two slides, I was just trying to figure out, is the chart the similar information you have in the graph?
Yes, sir.
And do you really need all that, because everybody's again looking at the numbers and not listening? Can you use your graph and somehow highlight whatever you want to set up things easier there rather than having both?
I guess what's more preferable for the audience? Is it better to look at a graph or look at a chart?
Sure.
The graph. Okay, so force one.
Megan, I think the only thing that the graph or the chart adds is the N. So you could make your force plot bigger and put the N under the FDR, SDR, and FC.
Okay.
I also think you should explain what a forest plot is, like that one indicates no difference, or like you need to, people are not necessarily going to know what a forest plot is, so just, you have time, like explain when you first put up the graph, one shows no difference, etc. Like just explain it to people what a hazard ratio is.
Assuming your graph is figure 2.
I don't hear one.
But you don't need to figure it all.
Right.
I mean, you're not, this isn't the paper, so I would just take the figure off of that. You could make the text bigger, you could make the plot bigger, you could add I think the numbers, for me, more so than the take home, is just the sheer number of patients that you had to work with. That's going to lead to significant, if those numbers would have been 50 apart, they still would have been significant, just based on the numbers that you have. But I think if you make that whole plot bigger and spend more time on it, it probably would be better off, because you basically have 2 result slides.
Right.
So you can talk a little bit more to those slides.
And just add the ends on page 1.
Yeah, I think along the same lines, I think there was, and I guess maybe this goes to what Dr. Skate was saying too, that it seemed like it took you a long time to get through your first 2 slides. And maybe either shorten them or make more slides that you can kind of go through more quickly or something, but it seems like it just kind of got really bogged down at the beginning.
When you were describing the cohort, you used a lot of words to describe that. And I think just think about, when you're going through this before you do the Inquirer, think about how you can summarize that. So to me, what you were talking about were people with heritable disorders or collagen vascular diseases that predispose them. and that you were describing it, instead of just synthesizing it, and that it worked.
And I think part of it is me trying to compare it to Mark, since everybody knows Mark.
Right.
Is there any way you could put a demographic slide up, like what were the ages of this cohort, what were the gender? Just add a little bit more to your results section.
Please remember to silence all phones.
No, I can definitely.
With your background, I think like one of the things to think about is really sell the problem. So like this will help you be concise too. And this is a thing that my colleagues speak about when I presented at grants. You know, you want to really like newsflash, like people are being underdiagnosed. This is a problem. Just have a couple of bullets. So like your doctor got a newsflash, like American Indians are getting screened, and now I'm interested. And so really have something that wakes up your people and as part of your introduction. For the Utah Population Database, that's an amazing resource. And if you're not from Utah, you don't know what that is, unless you're familiar with some literature. So if you talk to Sarah Halpern in the research office, there are paragraphs and slides that a lot of us that write UPDB grants use to kind of sell that resource. That it makes it very flashy. It talks about how big the database is, how well encompassing. I might steal one of those slides and just headline it because it's not like
You have a huge population, and there hasn't been any other studies with that similar number.
Which is super fashion when you're selling the grant, but it kind of got lost in your talk, and you kind of said, oh, by the way, like my ends are really good. You want to have a slide, like this is my methods, I use this database, this is what this database is. How big it is. And then when you do your ICD,
I think you to summarize that.
Yeah, put a UPDB slide on your, with methods numbers, because you have a little time. When you talk about ICDs, use your ICD-10s, because they are a much bigger pain in the butt than ICD-9s to code for.
And honestly, we use all the way back to ICD-6.
Yeah, so, put that in there, because you guys probably, Heidi did a lot of work modifying that for you, and so if you're, if you would have done that, it conveys something if you did 6 to 10. That's a big search, so you guys should get credit for it. Don't introduce, don't say first I'm going to talk about this, next I'm going to talk about this other thing. If you have to have that explanation, have an outline for the thing or something. Or don't say first and second, just show people stuff. And then I would put your next steps on a separate slide from your conclusion. And in your conclusion slide, you said kind of an important take-home that I didn't see written, which is that maybe people aren't being screened appropriately. Write that out and make that your last sentence. Because again, it's attention getting. Okay, so we have a problem, that's like your headline. Then you do a bunch of research, and then the last thing you should say is, wow, this is a problem, this is what we're going to do about it. And that is a good statement.
But be careful, because your conclusion should be supported by what you're presenting, so you don't know if the population is being a population is being underscreened.
That's why I try to suggest.
Right.
So just use those words. Say suggest or applies. More work is needed. That's great.
I actually thought you did a pretty good job selling the problem. I heard one sentence that was missing that could have been emphasized more, but it was kind of like, this is a deadly problem, and if we knew who was screened, we could actually prevent it. And so I think you have a good sell that you could probably emphasize more. And then there was one thing, though, and I think it was earlier than this, but you were kind of explaining the difference between sporadic and familial, and I'm not sure that in this audience that you really need to do that. So I would spend time elsewhere.
I think you could put up a big picture of a CT with a big giant and say, thoracic aneurysms kill people. And that's your, and seriously, people who've been here long enough have heard me say that every single talk needs to have a hook at the very beginning. There needs to be a reason that you want to listen to the talk.
All right.
Yeah.
I think I had a thing on the next person's coming up.
Sure.
Just can you
Whenever you're giving a talk in a forum like that, bring a piece of notebook paper and write down the suggestions at the end of the talk, because you're going to forget half of what we suggested, because you're nervous about your talk. So there's nothing wrong when you're presenting at you and here, or when we do a presentation here, you're going to get feedback. Bring something to write your feedback around, because otherwise you'll forget.
Or even better is if you have a friend in the audience, which today everybody should, right? Then have them take notes for you, because they'll be able to do that much better.
I also think that you should be prepared to bring something to write down, not your feedback, but your questions. So again, when you're in a meeting for 3 days in a row, when someone says, I'm sorry, I forgot your second question, it's so tedious to listen to in the audience, and it's so unprofessional. So write in shorthand, and it's really professional to write in shorthand, like, I'm Dr. Smith from Indiana, I have my 3 questions, and you write down Smith, and the 3 questions, and you say, thank you for your questions, Dr. Smith. And then you answer all 3 of the questions because you wrote them down.
All right, so I have an 8-minute presentation on the impact of insurance expansion on the length of stay and disposition for pediatric trauma patients. We have nothing to disclose.
Okay. Can you discuss this with you?
Yes,
Okay.
I have discussed this with both of my managers.
Okay. Yeah.
We have nothing to disclose. Multiple previous studies have documented significant disparities in pediatric trauma care, particularly around the use of post-disposition resources, such as discharges of home health or discharges to inpatient rehabilitation. These previous studies have demonstrated that insurance status has a significant impact on access to these resources, with those pediatric patients that are uninsured or underinsured having decreased access to post-disposition resources that are sorely needed. This graph from the Policy Institute at Georgetown University demonstrates that despite the fact that the Affordable Care Act did not specifically target pediatric patients, over the last 6 years there have been significant decreases in the number of uninsured pediatric patients, with a significant drop between 2013 to 2014 with the expansion of Medicaid through the Affordable Care Act. There are multiple reasons why this might be the case, including improved education for parents and increased eligibility of parents, which led them to enroll their previously eligible children at much higher rates than previously. Previous studies in the adult population have demonstrated that the expansion of Medicaid through the Affordable Care Act, such as this study by Scott et al., have had significant impacts on adult trauma patients' access to post-disposition resources and length of stay. Their study demonstrated while there was no change in mortality, there were significant increases in access to home health as well as to a post-acute care facility such as a SNF, an LTAC, or inpatient rehabilitation. Our research question was, do these changes in pediatric insurance result in significant impact on the disposition of pediatric trauma patients from 2012 to 2016? And our hypothesis was that similar to the adult population, increases in insurance coverage would lead to increased utilization of post-disposition resources. We used the National Trauma Data Bank, which is an administrative database of all trauma patients from 2012 to 2016. And we included all pediatric trauma patients who had an abbreviated injury score with the highest severity body system greater than 2, meaning we selected for the most severely injured pediatric patients who were most likely to need home health or access to a post-acute care facility. Our 2 main outcomes were the inpatient length of stay and the location of disposition. We used a multivariable regression model and presented our results with an adjusted risk difference, as we felt that this was a more easily understood metric than a risk or odds ratio. We also completed a subset analysis of high-volume hospitals treating more than 100 pediatric patients per year and looked at the degree of change in Medicaid and private insurance. We identified just under 200,000 pediatric trauma patients in this time period, with a mean age of 9.3 years. 2/3 of them were male, and the 3 most common mechanisms of injury were fall, motor vehicle collision, and pedestrian or bicyclist versus vehicle. The mean highest body system AIS was 3.4, with the most severely injured systems being the head, thorax, and abdomen. We identified that 1/4 of these patients were treated at a level 1 trauma center, with the majority being treated at level 2, level 3, or non-trauma center hospitals. The majority of these hospitals were university teaching hospitals, with an additional 30% being community teaching hospitals. When we looked at the change in insurance coverage in our population, we identified significant changes that included a significant increase in private insurance over this time period, a significant increase in Medicaid, as well as significant decreases in those that are self-pay or have other types of insurance. We then looked at our outcomes of interest. We would expect with this increase in insurance coverage that we would see a decrease in length of stay, as disposition would be facilitated by increased insurance. The length of stay across this entire time period was approximately 4 days, with statistically significant but clinically insignificant changes with an increased length of stay of 0.2 days. We then looked at our next outcome, which is disposition with home health. Again, we would expect an increase in home health utilization with increase in insurance. We did see an increase in discharges with home health that were statistically significant. This graph on the y-axis shows the adjusted risk difference, and the x-axis shows the year. All of these changes from the baseline in 2012 were statistically significant. However, they were small, with less than 1% increase. We then looked at our final outcome, which was a discharge to post-acute care facilities, such as a skilled nursing facility, long-term acute care facility, or inpatient rehabilitation, and we expected to see increases in these as well. This graph again shows an adjusted risk difference. However, you'll note that 0 is at the top, and these differences are actually negative, meaning there were decreases in discharge to post-acute care facilities for pediatric patients. These differences were significant in 2013, 2014, and 2016, showing that despite increases in insurance, patients were less likely to go to post-acute care. We then did a subset analysis of high-volume hospitals and grouped by the percent change in Medicaid or private insurance to see if there was a high change subgroup that might show gains that we didn't see in the overall population. This graph shows the change in discharge rate to post-acute care facilities in each group is a different percent change in Medicaid. For all groups, there were significant decreases in discharge to post-acute care despite increases in insurance. We then looked at the same type of graph for private insurance, and again, there were decreased discharges to post-acute care facilities in all groups despite the increase in insurance. The limitations of this study, this data set does not include all hospitals, and we also may fail to capture discharge to internal rehabilitation centers. At our own facility, most patients are discharged to rehab within the hospital, which would not be documented in this data set. Secondly, are we really looking at the most meaningful outpatient outcomes for pediatric patients? Are their discharge needs different than adults? So why do we not see the expected gains that are seen in the adult population? There are multiple possible explanations. One, there may simply be no more pediatric inpatient beds that are available. There may be geographic barriers with some patients unable to access inpatient rehab for pediatric patients in their area, and they may have different needs than adults. They may need more long-term TBI type rehab rather than acute rehab that we see in adults. So in conclusion, we saw expanded insurance coverage in this time period for pediatric patients and changes in resource use, but they were not the changes that we expected. And our next steps are to look for what kind of barriers did we fail to capture in the study. Thank you, and I'll take any questions.
Still got a minute to go. Yeah.
That was really, really great presentation style, really nice slides. I have a couple comments. If you could go back to your very first slide. Well, as you're doing that, I think I'll say, I think one of your most important conclusions that you might have missed, which maybe I'm wrong, but struck out to me, is that it may be that your decrease in rehab discharges is because of your increased length of stay. Patients are staying longer, so they don't need a rehab discharge. And maybe because they're insured, people are being willing to keep them in the hospital longer if they have insurance. And I wonder if that's a conclusion that you should identify. I would say that I would work on your intro, because what's going to happen is they're going to say the next presentation is University of Utah, Intermountain, and Pediatric Hospital, Dr. Pruitt, Luker, and McCrum, representing authors, Dr. Pruitt, on the impact of insurance expansion for length of stay and disposition for pediatric trauma patients. And then you got up and said, thank you, I'm presenting the impact of insurance expansion on length of stay. And so you repeated the slide. So what you could say is, thank you, Dr. Pinkron, click, we have no disclosures. Today I'm here to talk about So your first sentence is your background sentence. That's my style, and my suggestion is just a style. It might be wrong, but I do think that it sounds funny when you repeat the title that they just said. The one other question, comment that I have is on your graph that, of the Medicaid increase, the insurance. You have another minute, yes, that one. Maybe you could explain what other is?
Okay.
I don't know what other is.
Yeah, most of it is military insurance for children. But it's also in this database, it just says other. So I don't know exactly what falls into that category other than the military insurance.
Maybe you could put military / other so people know what the majority of it is. Because to not know what people have is unusual with insurance.
The other thing from this graph, which is unusual since you're doing a change in coverage, so it's a population that's always going to be based on 0. You've got a lot more positive than you do negative. So how does that reconcile itself? Because people should either be private, self-pay, military, other government, and all of a sudden private insurance goes up, but Medicaid also goes up, other goes down, and that underinsured. I had a hard time with that, trying to figure out. So all of a sudden you've got more kids, maybe, I don't know. But if it's a percent of a population, that it shouldn't have. Those numbers should be.
But it's percent, not total. I mean,
Well,
It should come back to 0, so the amount down should be the
ups and
amount
downs
up.
should be,
Yeah.
Well, self-pay does go down. I know it's not impressive on this graph, which is, it's better this than when you look at the percent of the population over time, because these are small, it's 1 to 2%, but self-pay goes down by almost 2% and other goes down significantly, and that's how it does balance out.
It doesn't look visually look that way, so.
And to Dr. Stape's point about the length of stay, I think we've talked about that extensively, but the length of stay only increased by 0.2 days, and so I don't think most rehab stays are more than like 1 day, and so it doesn't really, the numbers don't really reconcile unless there are a lot of outliers.
I must have misheard you then. You might want to say 0.2 because I heard you say 2 days.
Okay.
So I misunderstood you. Thank you.
Let's see.
Early on in the presentation, you used the term post-disposition a number of times. Do you want to say that, or do you want to say post-discharge?
Sorry, it should have been post-discharge, but I misspoke.
Go to your first couple slides. Next, there's one where you keep going. Keep going. So this one, this one. So here you have a lot of free space. You have stuff that's low font, and what is your point? And so you talk about what your point is. You need to synthesize and not use this copied table. Synthesize the data and make your own slide, and because the information you have is in the box, not in the
yeah. The other thing I would suggest with this is to move everything up so you have blank space at the bottom, not the top.
And then you have a lot of, and this is just made my software, I know you want to reference where you're getting your information from. But there's nobody that's going to take it's cumbersome to have all this writing, detailed reference. So you can have some little short reference and put the major thing in your notes.
Can you go to your other graphs, the binary results about the changes, like in the next one, right here. So, and this just might be me, or I missed something that you said, but I was looking at these and saying, how can they statistically be different compared to each other? And then you said this is compared to 2012, and then it made sense. But at first it was, to me it was confusing. I don't know if other people understood that it was compared to 2012.
I did not. And
So you're missing the reference point. So is there a better way to show that, or to add 2012 somehow? So people
The link with the star means.
Yeah, and I guess I can take the time, I have a minute to explain what adjusted risk differences, because I can't, because it's a risk difference, I guess I could put 2012 on there as 0, but that's the difference that is subtracted out. So it's not easy to represent graphically, but I can do a better job of describing it.
Or maybe the title changes in discharge and how compared to 2012.
I don't know, that was, like I said, my first thought was, how much is difference there? Error running overlapping things that
Let's go through some chart. something, you had the tables. So, yeah, no, let's go back to that. In both of these, what's your parentheses?
Standard deviation.
Oh, there's up there. I didn't miss that up there. See where that is.
Maybe just shift your line over a little bit
Yeah,
so that
move-
pops up to the same line.
Yeah.
Would it also make sense or make it easier for the audience if they were ordered in the number of like from highest to lowest, just because otherwise you're kind of like looking around like, oh, there's the top one, but then where's the next?
And I always struggle with this when I'm presenting tables. And something that I found helpful, and you can choose to do this or not, but maybe is put a red star by the key points that you're talking. If you don't line it up from smallest to lowest or highest to smallest difference, putting stars in, because you're doing that verbally, and that way it cues the audience to out of all of this, which is important to see these differences, these are the key points.
Yeah, I think as someone go to your other, the graphs you were just showing, like the compared to, where everything was negative. Not that one.
Yeah.
Yeah, that one. Kind of along the same lines, like, I mean, you did a good job of mentioning that zeros at the top, but maybe having something else that highlights that visually. Yeah.
You could, on that, if you want to make it like that, instead of having the x-axis line at the bottom, you have it up at the top, 0. So everybody sees it.
What's the next one? You have to look at the screen because it's coming off. Go to the top.
So I have a second 8-minute presentation, and I have reviewed this with my mentor. Thank you. We have no disclosures. In 1991, the National VA Surgical Risk Study was initiated after an act of Congress to better understand post-op outcomes in the VA system. In 1994, this was renamed and expanded to non-VA hospitals and called the National Surgical Quality Improvement Program, or NSQIP. In 2012, the American College of Surgeons expanded NSQIP to include children's hospitals. Previous studies in the adult population looking at outcomes, such as this paper by Dimmick et al., had failed to show a benefit of the NSQIP practice on surgical outcomes. Even in the first 3 years, they saw no improvement in mortality or significant postoperative complications. However, the pediatric surgical population is very different than the adult surgical population. There's very low morbidity and mortality in this population, and there are far more dedicated children's hospitals that have already subspecialized. So there is potential for the pediatric NSQIP population to be quite different. We chose to focus on the neonatal surgical population because despite representing a small proportion of the total patients sampled in pediatric NSQIP, they represent more than half of the mortality captured in pediatric NSQIP and a disproportionate amount of morbidity captured. Our research question was, did the rollout of NSQIP pediatric improve outcomes for neonatal surgical procedures? And our hypothesis was that they would have equivalent outcomes to non-NSQIP freestanding children's hospitals, similar to the adult population. We use the Pediatric Health Information Services Database, which is an administrative database of nearly 50 freestanding children's hospitals across the United States. We looked from 2008 to 2015, and we excluded patients treated in 2012 as a washout period for the initiation of pediatric NSQIP. We included all hospitals that joined NSQIP in 2012, as well as hospitals that did not participate in NSQIP during the study timeframe. And we excluded hospitals who joined NSQIP midway through the study. We included 6 neonatal procedures that account for a significant amount of neonatal morbidity and mortality, including pull-throughs for Hirschsprung's disease, repairs of tracheoesophageal fistulas, congenital diaphragmatic hernia repairs, gastroschisis and omphalocele closures, as well as neonatal bowel resection in the first 30 days of life. Our outcomes of interest included mortality during index or admission, condition-specific reoperation, surgical site infection, and pneumonia. We use an adjusted difference in difference model. And we use this model because it allows us to differentiate between differences over time in the entire population and differences specifically related to the policy. This slide demonstrates two changing populations, an intervention group and a control group. You'll see that they both decrease at the same rate, meaning that despite the fact that they both change over time, there's no specific difference in that change based on the intervention or not. Contrast this to this slide, which shows in the dotted line and what would be expected if there is no impact in the policy, and the solid line, which shows that there's a significantly increased difference with the policy. This difference in difference, or the difference between those two lines, demonstrates the impact of the policy. We identified 24 hospitals that participated in NISQIP and were included in the FIS database, and 11 hospitals that did not participate in NISQIP, and excluded 6 hospitals that joined NISQIP during our study period. We identified 3,500 patients treated at NISQIP hospitals and 1,200 patients treated at non-NISQIP hospitals, with the most common conditions treated being gastroschisis and Hirschsprung's disease. The gestational age was somewhat lower, although not statistically significantly different at non-NISQIP hospitals, with a similar rate of significant congenital anomalies. Looking at non-adjusted rates, with the rate of the complication shown on the left and time on the x-axis, we saw no significant difference in mortality rate between the two groups over this time period. Showing a similar graph for the surgical site infection rate, while there appear to be differences, these differences were not statistically significant over this time period. For pneumonia, the rates were extremely low and there were no significant differences in the pre and post time period in either group. And for reoperation specific to the condition, we saw no significant change in the non-NISQIP group. However, there was a statistically significant decrease in reoperation shown at NISQIP hospitals. Using our multivariable difference in difference model, we saw similar effects, with no significant impact on mortality, pneumonia, or surgical site infection, but a significant decrease in reoperation at NISQIP hospitals compared to non-NISQIP hospitals. The limitations of the study: this database only includes freestanding children's hospitals, which may already be significantly different than other hospitals that treat children across the country, and a self-selected group of hospitals presumably joined NISQIP. So this is not a randomized study. These hospitals were already different at baseline. We're also limited by our ability to identify clinically meaningful outcomes in administrative data, particularly the codes for surgical site infection and pneumonia probably do not capture these outcomes in their entirety, and one of the advantages of NISQIP is manual nurse review to better capture these outcomes. The implications of this study: it's one of multiple studies that do not indicate that NISQIP provides very many significant changes in outcomes across groups, even in this selected high-risk neonatal group. So what do we do next? So we only showed that NISQIP pediatric includes one neonatal surgical outcome, which was reoperation, with no impact on mortality, surgical site infection, or pneumonia. So are there better, more cost-effective ways to improve outcomes than the high-cost NISQIP programs, such as surgical specialization or regionalization to improve surgeon volumes? Thank you. I'll take your questions.
Yeah, you get 2 more minutes on that one, so you can feel free to add and enhance.
What's a puff?
Yeah.
Oh, that's the name of the file for the pediatric NISQIP, so I'll relabel that. Sorry, I'll use that for another test.
Stay on that slide. So, it's great that you have the 63% and the 18%. I think you said for you guys were like 2% or something. Can you just put that percentage just so
For your conclusion, Lisa, do you want to say, I think you were kind of rushing, but do you want to say something about just improving surgeon volume, or do you want to emphasize also hospital volume?
I should mention both, because they're both actively being discussed in the pediatric surgical population.
Right. You know I'm going to get you on this one. Your chart that you copied from somewhere.
Yeah, it's the same thing as the last one. Yeah.
Nothing drives me more crazy than something like that. So
to Dr. Price's point, it's never happened to me ever, but when you're in a big room and there's nothing at the top, but there's something, sometimes short people can't see the bottom of the slide.
So go to the previous slide. Okay, that's right, go to the next one. Because here you have this table you take out as a paper, right? Because it is something, that you could have that, you have a whole wide area, and you can put what the point is that it makes, it's actually there.
And then still on this slide, when you referred to the study, you said DIMIC.
Yeah,
Such a big problem. They might be nice.
The pediatric surgical room, so I might leave it. Never know.
You talked about the difference in difference analysis.
Yeah.
You didn't make any mention about adjusting for risk adjustment. I'm assuming that you did some kind of risk adjustment analysis, right? I didn't remember seeing anything like that. I just missed that.
I said that we did, I just mentioned that it was multivariable, but I can be more explicit about what patient covariates that we included.
Right there when you're talking about difference in difference, that you did do a risk adjustment. Then since you do have, it sounds like you have, did you go over time?
No,
So you have a little bit of time to talk a little bit more about what the risk adjustment was about. What did you adjust for?
We adjusted for gestational age, birth weight, all the major congenital anomalies that are included in the database, as well as possible one.
Go to your table. Both of this one and the last one. Your pen with the parentheses, percentage, put that over in the, rather than over the words, put it over where you're.
Yeah, on your table here, you kept saying congenital anomalies, but you have cardiac anomalies. Was that a?
There's like 15 different
Because these are all
anomalies.
congenital anomalies except for.
Well, gestational age is not.
Well, I mean your conditions.
My condition.
Except for neonatal bowel resection. Okay.
Other non-surgical, because like we adjusted for neurologic anomalies, cardiac anomalies. Like there's a lot of other things we adjusted for, but it would be like I could do that. We had time to do more.
Just put other anomalies instead of cardiac.
Yeah, because you were kind of going down your list, and then at the very end you said congenital, and I couldn't tell if you meant congenital or cardiac.
So same kind of thing, can you label, what your percentage pregnancies are there?
I can. I'll have to reformat it because gestational age is not N%. So that's why I put it over with what the item is, because that's different than the condition. But I can put it inside the sheet.
I'm lost in that too a little bit too. So remind me, why is gestational age, so you're adjusting for it?
We're adjusting for it, and most pediatric surgeons, that is like the patient demographic that they are most interested in.
But your your conditions, you're adjusting for each condition.
Well, this is just demonstrating what our patient population. This is like a demographic slide.
So could you separate the two? Like, could you have, here's my demographics, and then we did adjust for the following factors. I think maybe that's where I'm getting lost, is like, are you adjusting for gastroschisis, or you're just looking at these populations and your adjustments are the things further down, right? Can you also pull up, sorry, I took this down, you guys. Your method slide, your first graph there. Can you label the y-axis?
Yeah.
Please. And then can you also, so on subsequent slides, you kind of write pre-ness with post-ness, but can you do the same thing? So if you walk in the room, read the page.
Well, this is just a demonstration.
This is an example.
This is an example.
This is just what is a difference in difference model.
Okay, and then can you write that?
Could you change the title from methods to that?
Yeah.
Yeah.
That this presentation also maybe could have, you summarized it really nicely in the end, but like Dr. Ivo mentioned earlier, you would have benefited from some, statement that draws you in a little bit more succinctly, in the age of value-based care, we're searching for ways to measure outcomes and improve outcomes, period. That's quick is one of the ways, and then talk about how you investigated, does this really capture that in this population?
To emphasize that you're explaining what a difference in difference analysis is, people are thinking results of AR methods, right? You might want to just pose the question and say, so what is a difference in difference analysis? This is an example, so it gets people to start thinking differently about what you're talking about.
Also, the next slide, the classic DAD example thing has like a pre-existing trend, vital
thought to grow the bar with dimensions.
Yeah, we can add that.
So it's a little unclear where on the x-axis pre-was placed.
I think to these slides, not just that one through having a title, but that really is.
Yeah, just one minor grammatical. You said something in there earlier about hospitals who, but yeah, it should be, who is usually a person.
And then with your conclusion that, you kind of said something like, does it make sense to use such an expensive intervention to just get one result? You have shown that that statistically it looks like the reoperation rate went down after the institution was split, but it may not actually be related to the split, right? It could be something else. Maybe it's increased use of interventional radiology over that time period or something. So you could probably even emphasize that. Like your point is very important.
You'd hope that, I mean, that's part of the reason to do difference in difference, right? Is that you'd think if it was in fact interventional radiology or changing practice patterns, those other 11 children's hospitals would show similar change in practice patterns.
Go to controversy. Conclusion. We should be implementing this. But in all seriousness, like you say volume, and you haven't said anything about volume to date, so it was a little bit. I don't know what the conclusion this should be. But I would challenge whether this huge investment is really worth it.
Unfortunately, so right now, ACS is also doing the Children's Verification Program, which is similar to trauma centers. They're giving levels to all the pediatric surgical centers, and to qualify to be a level 1 Children's Verified Center, you must participate in FESIS. So, I don't think it's going to be.
It's not self-serving at all.
All right, well, thank you very much. All right, good work, everybody. We'll get indications. Oh, wait, hang on.
Can I just, so like really quickly, folks have asked me to just a couple of quick statements about, so professionalism in research. So we had some discussion about this in GEC. Kind of a shout out to like run things by our mentors. So it works both ways. So kind of as a mentor, for example, like I got invited on Sunday night at 10 o'clock p.m. to be a co-investigator on a grant that someone was submitting, and it was due at 10 a.m. the next morning. And my response was, it's Sunday night, I'm with my family, I haven't read your grant, I have no idea if I agree with what you're saying or not, and that's a colossal inconvenience to me, right? So, kind of as a mentor, like just given my recent experience, please like give your surgeon mentors time to read your work and comment on things. Remember, we're on a call too, we have families all kind of stuff going on just like you guys do. So if you are, kind of down to the wire with what you're writing, and then you then hand it to us, and we have to go to the OR tonight, you may not get a chance to read something. We want to read it and have a chance to kind of give you feedback and commentary on it before you present it in a forum, and especially before you submit it to a meeting, an abstract submission form publication. So budget into your kind of deadline, not the deadline right before something is due to some external forum, but give yourself like a good, 2, 3, 4 weeks, depending on the complexity of what you're doing, to give your mentor time to go over something and get back to you about it. If you're having trouble getting in touch with a mentor, the program director's office is going to be advocates. So if you're reaching out to somebody, they're super busy, they're not getting back to you, sometimes a gentle email from another attending physician can be a motivator to respond to you. Dr. State has comments.
Well, I just would add, not just your mentor, all co-authors. If someone's name is up there, you're representing them, and they need an opportunity to decide if they want to be represented in that way. I had one example in my fellowship where a medical oncology faculty completely disagreed with the conclusions and asked for his name to be taken off the paper. Totally appropriate, right? So you are representing everyone whose name is up there, and they must have an opportunity to review it before you represent them.
I guess I will add on one thing with regards to timelines is if you have a presentation that's due and you plan on doing UTS nights and the SICU for the 8 weeks beforehand, it is unreasonable for you to think that you're going to be able to get that done. So you need to budget into that timeline that you're going to get this done 4 months in advance. And you're just going to be doing minor edits up until that point. And these things should be discussed with your mentor. And you also need to discuss with your mentor if somebody had something to do, was doing something with me and it was due the middle of June. Well, I'm going to Europe for 3.5 weeks. Okay, so I'm not going to be here, and what I'm not going to do is edit a presentation or a manuscript from Europe. I mean, that's just not going to happen. No.
It doesn't hurt to check in with us about stuff. So, like, if you know you're going to be on youth nights, maybe like Dr. Snape doesn't, right? Or if you're going to go out of the country and be off the grid for a week in some meeting, just talk to your mentor and say, boy, I'm trying to plan this out. Like, I know we've got this submission coming up in a few months. I'm going to be on youth nights, like this and that. I'm going to be really busy. You know, when can we do stuff? And just anticipate those kind of things, or to the best that you can. Communication is encouraged.
And I will close this whole discussion by basically saying that we discussed today in our faculty meeting the use of professional development funds for travel that's not been presented or vetted in a timely fashion with your mentors. And we have twice in the past not allowed somebody to travel and not allowed them to present at a meeting because they did not get something done on time. That handing something in 6 hours before it's due and expecting it to be edited is inappropriate. So just understand that these are things that we're talking about. You took on a responsibility by taking on a project. That means it's your responsibility to come up with a timeline for said project that's consistent with your rotation schedules and the faculty members' time, and you're responsible for getting it done. And our expectation is that you guys are going to get things done, or else you shouldn't sign up for them.
And again, just one more thing, like Dr. Eibel said, if you're trying to reach your mentor and you're not getting any response, let us know, and we'll help facilitate that. But the same thing goes the other way too. So if your mentor is reaching out to you guys and you're not hearing back because you're super busy, they're going to call us and we're going to try to get in touch with you guys too. So just that's there for everybody.
Alright, bathroom break, education, bathroom break. We only have 2 cases, so we'll actually get
No, I did not.
Yeah, no, I know.
No, you're kind No, his story was that we were starting so, yeah, back on the day off. So,
Figuring out how much it is, figure out how much you Slashing around her neck.
Alright, let's start with indications. So we saw a patient in the ED at the VA mid last month. He was complaining of perirectal pain. He said it was 6 days of pain, fullness on the right, and some blood on his toilet paper. He'd seen his PCP a couple days earlier. We diagnosed him with thrombosed external hemorrhoids. He had increasing pain, and also inability to void. And so he came into the ED to be evaluated. He diabetic. I remember him being more obese than 30, but that's what the chart said. It's 30. Never changed it. I've got a physical exam on the next, a picture on the next slide, but he was tachycardic but afebrile.
So, you can ask that question.
Yeah.
Let's stop asking questions.
Okay, let's stop asking. We'll pick a differential diagnosis. That's what it is.
That's a great question.
Okay. So versus abscess, a thrombosed external hemorrhoid. It could be some sort of infection secondary to a fistula. It could be venereal disease. It could be rectal or anal cancer.
Sure. Any others? Pelvic sepsis, yeah. And then, whenever you're talking about perianal stuff, you want to flesh out a differential. You can add, you said cancer, but Crohn's or something along those lines, the complications from other things, HIV, you can pick up some of those stuff as well. So, we'll come back to that. Hydradenitis, proctitis, some others. We'll go back to this picture. So, sick guy can't, well, he's in pain, right? He's got tachycardia. He can't pee. So, any other thoughts before we?
And go back to your, not that one. So you said that's thrombosed overlying skin.
Did I say that?
Go back, yeah, that's what it says right there. It says inflamed fullness with thrombosed overlying skin.
Oh, tract overlying skin.
Okay, yeah, it's not thrombosed.
Okay, sorry.
Back to the picture.
So that's what it looks like. So that's what we got. What's that? Does it change anything for us, Mark?
Sorry, what changed?
Does this picture of physical exam change? We had pretty broad differential coming in.
It's turning away. Yes.
I think this is, let's see, this is the right side of the pelvis. I'd say this is sacrum.
We can't see
Oh, we
it.
can't. Sacrum's over here.
Those are thighs.
Thighs.
And I'm assuming the area on the top portion of the screen is indurated.
Right posterior, yeah.
Is it indurated? Is it fluctuant?
Indurated tender fluctuant.
Then that would make me more suspicious of any kind of perianal abscess.
Okay,
Or
so
perirectal
should we
abscess.
book him and just take him to the OR for?
Well, initially, he was tachycardic, right?
Tachycardic.
I'd initiate treatment of sepsis, including fluid administration as well as IV antibiotic initiation, and yeah, book him.
Hey Jim, why can't he pee?
Why can't he pee?
Oh, and I put a hole in. I imagine it was the inflammation in the region.
So what's that called? They're pretty much
Neurogenic bladder.
That's on the.
That's where the front.
That's true. Are you talking about perineal sepsis or pelvic sepsis?
Pelvic sepsis, yeah.
Okay.
What's pelvic sepsis?
Pelvic sepsis is the constellation of a pelvic inflammatory process plus septic picture plus insulated void.
Pain, fever, and insulated void. Yeah, he doesn't quite have a fever, but I think with the previous picture that should be on the differential, yeah, for sure.
So I think the other important part of the exam is that whether he has crepitus around that area or not. So we've got that and diabetic. Yeah, you worry about a necrotic soft tissue infection as well.
Right. I didn't examine this one. I don't think it crepitus was important.
No.
But it would change your operation drastically.
Right. So we did get we got labs as well, and then.
Can we go back to that picture?
Yes.
Sorry, but we spend a lot of time like teeing people up to take them to the operating room and blah, 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 and maybe ICU or resuscitation, and there's gangrenous tissue in there. I try to like do that, get pus to start draining out, and then start doing all of those things.
Good thought. You did not do that.
I mean, it's almost open itself, right?
Right.
You can resuscitate the patient as much as you want, but as soon as, until that pus is coming out of there, he's not going to get better.
And just so Courtney doesn't sound like an outlier, I was struck with this in the ER too.
Alright, so Dr. Pigron's kind of itching because he's nervous that we're missing something. Our differential could be, we're kind of leaning towards abscess. This guy's, you mentioned, he's diabetic and sick, or borderline sick. So we did get a scan as well of him, or it was actually done for the college, but in this case, it probably wasn't a bad idea.
So, by the way, go back to the, so his white count wasn't very impressive, but this is actually just above the threshold for abnormal at VA, which is actually the difference threshold.
Alright, and then his lab are largely normal though, not as sick as you might expect. This is one shot of, you gotta follow the for that. And then this is some shots down lower as well. Really,
So the first shot showed a extended bladder. This, looking at the abscess, it looks like it is like a horseshoe configuration on that axial cut. But it's it's a multiple 5-6 centimeters.
does that change your surgical plan at all?
You still want to drain it. I still think you could poke it, but you're probably, if it's a horseshoe abscess, then you're more likely to do it in an operating room and potentially need to have a Penrose drain in.
Penrose, is that the surgery we do for horseshoe abscess?
Depending on where it is.
How about we bump it up? Horseshoe abscesses. Yeah, we'll go with the Josh Flaker. What do you mean for horseshoe abscesses?
So horseshoe abscess, you need to drain the deep post-anal space. And so you would drain both sides and then have connecting counter incision in the posterior midline to connect those and then lead Penrose through all those spaces so that there was one big open space to drain, but you have to make sure you drain the deep post-anal.
Modified hand.
What's that, Miss?
You'd also look like closely for posterior.
Yeah, exactly. That's probably maybe the most important portion of it is to look for that posterior defect, posterior midline defect, maybe a Penrose or something through that space you're talking about, and then your counter incision drains as well. And we don't know that anymore, but Dr. Milosh does.
Well, the classic way that they describe this operation, you make an incision from the anus posteriorly back towards the coccyx to get into that space, then dissect out lateral, and that's where you make your counter incisions and place your drains. Deep post-anal spaces.
So this picture's upside down for me, but incision here, get into the space there, and find your defect here and get some Penrose or some sort of drains through that before you get your counter incision. If you want to be, this is not our patient, but this is the picture of an example. I don't see a drain coming out the anus of this one, so it's probably not a completed modified hand just yet.
So on your exam, it looked like there was only abscess on the right, but was there anything on the left on your exam as well? The CAT scan, look on your exam.
I actually didn't examine it yet. I don't think there was. He was tender bilateral, but it was right much greater left. It was tender, but not nearly as the right side.
Yeah, he actually, well, I didn't examine him. I didn't do a rectal exam before we were in the operating room. He was asleep. But and I don't think our resident who did this here actually, but what was reported is, he would actually tolerate a rectal exam, which is a little bit surprising to me in the ER with this problem. And there wasn't anything obvious on the left externally. You could see the area that was like a little bit circumferential, but it wasn't fluctuant or anything like that.
Well, because I think going back to Dr. Skate's point about just poking a hole in the thing. Yes, anyway.
Well, I think one of the reasons why this is interesting is because, most of the time we don't take these patients to the OR. And so I was actually a little bit skeptical when I first heard about this, about going to the OR that night, but then I saw the pictures and...
Oh, you mean for you just do it, right?
Yeah, and as Jim pointed out, the ER had obtained a CT scan before they called us, but without that CT scan, I mean, his lab values and vital signs were not too far out of range. And I don't think we necessarily, I wouldn't have appreciated just based on, you know, probably an exam in the ER how significant his problem was.
Yeah, I think that is tricky, I guess.
Yeah, that was a good takeaway, yeah.
So, I don't know, would you scan him with a tachycardia to that exam? And what kind of just...
I agree with Dr. Scanlon. You poke a hole in it, and if he gets better, then, you know, great. You know, and how much drainage you get and how, basically what you're able to do at the bedside would then determine whether you need to go to the OR.
Alright, so the plan's on.
No, I think
Assuming
you
saw the picture.
You saw the picture. I mean, I guess the one thing is that
Which picture? The picture of his butt or the CT scan?
the picture of the butt. Yeah. So without the CT scan, he's presuming that you don't walk with the ED. They shouldn't always be scanning every single person that walks in the ED. But I guess I know what they do. But when you put your finger, you know, the concern would be really on the rectal exam tells you a lot, right? So like a lot of times, you know, you not see a lot. You not see a lot on the external exam or just in sort of physical picture here when you put your finger in. If they have a lot of pain, especially bilateral, that would make me suspect that something else is going on. Or if the pain is only on the inside, right? If you have like a high abscess, that would prompt me to get imaging in that situation. But yeah, I agree. Like, you know, a lot of times you just poke these and then the problem is then they come back, then they recur, and that's when you get the imaging. You see that it's not fully treated.
So this was taken to the OR, and they started by, it sounds like breathing in the brain and necrotic tissue, which is a reasonable plan. And that necrotic tissue actually extended well up into the anal canal, the anal mucosa. So ultimately they got good sort of control drained well. So we took the patient back a few days later just to take a look at the scene. There was the sphincter complex was exposed and seemingly non-functional. So we just got good drainage in, washed him out, took him back to the port because we had consented him. But at this point he became incontinent of stool for liquids and solids. So what should we do then, Lisa?
I think in the acute setting, I don't know what I would do anything, like, because I don't really know that, like, I wouldn't want to do anything definitively, like, around his anus, because you don't really know what function he's going to have, like, this may be related to the inflammatory process, and maybe gain some function. I think you would have to assess whether or not I thought it was preventing, like, a sufficient volume to prevent wound healing, and if I thought he wasn't going to be able to, like, heal his perianal wound because of the, like, volume of stool, I would consider doing a diverted floss to make it. And if I thought it was manageable, I would not want to do anything.
That's what we did, yeah.
I guess back to indications for imaging, would him having urinary retention push you to get a CT scan?
Yeah, in hindsight, I think that like the borderline high white count, the tachycardia, and that inability to void, if you were to take a step back and think about it, that's not the classic perianal abscess, right? So that might be ultimately drainage is what he needs, and imaging if he's not following the normal course. But I don't think he would be called at 30 even in that setting.
So let's say that you didn't get imaging. You go into the OR, and you see a larger than expected quantity of pus coming out. I guess the other questions are, you don't have to have a CT to try to find a lot of these abscesses. I mean, it's a little bit harder. It's nice to have imaging. How do you normally find the first anal space if you're in the OR and you're trying to test whether that actually needs to be opened up formally?
Formally planned. I forgot your last name, I'm sorry.
How I decide if it needs to be opened up or not more?
Yeah, how do you tell if there's purulence? How do you tell what a post-anal space is? Or if there's purulence in the post-anal space, if you don't have an image?
Well, if it was tracking that direction, like towards the posterior midline, I would be suspicious that there was something that needed to be drained.
Okay, so then you're suspicious, so how do you find out for sure?
I could probe that direction from whatever, where is my opening right now.
You just
on
have a
the
little,
side.
you have a little incision out here.
Well,
Incision on there.
Every time just for hypothetical.
Okay.
So I have an incision on the kind of right lateral. I would just probe in that direction. If it was going easily, then I would be suspicious that I would need to open that.
The
side.
question is, how do you find the deep post-anal space? Like, if you were going to
Yeah.
say, I need to find it in this person, what incision would you make? How would you get
That
there?
would be that posterior midline incision that you make for the Hanley procedure with site.
So that, once you make that incision, you kind of commit yourself to another wound there. Let's say you're not sure. So you're going to probe you probe that right lateral side, and what you're going to get is a bunch of inflammation, and you can't get it all the way to the midline, but it tracks back there, and you're following good cells where you're going to wonder, okay, is it curving back there? But there's something else you can do in the OR very quickly to make sure that the post-anal space isn't affected.
Could make an incision on the left, and if there's purulence on the left as well, there'd be concern.
Okay, so if there's not, then you have another.
Put a needle in it. So you go right below the coccyx and the anacoccygeal ligament, put a needle, 18 gauge needle, and aspirate and see if it puffs.
And that would tell you should be.
And sometimes those shorter needles aren't giving enough, so you get like a spinal needle or one of the longer ones. And you're gonna have to, when you break open that anacoccygeal ligament, it's pretty thick. And so you're gonna have to push to get that needle into, it'll pop into that space, and then you can aspirate. And if you're not sure and you don't have imaging, but you're in the OR, you can still find a lot of these deep ones with a long needle and probing and suctioning back. So don't feel like you have to like get out of the OR and then go get an image and then come back to the OR.
But a big needle, the plus is thick.
Yeah, it's got to be at least 18
gauge.
gauge.
Do you ever just ultrasound this and operate and look to see if there's fluid back there before you start cramping? This sounds terrible.
Where do you get ultrasound?
I can't say that every mind that ultrasound live
The other thing I would add though is don't over aggressively probe from your IMD side. Because all the issue rectal space is just fat.
Yeah.
So anything that you put a probe through, it's going to go there. So don't make tracks that aren't there. Don't spread stuff that's not there.
So the sphincter complex right between the two. You just take a long needle, I like to take a spinal needle and just stick it in there and pull out. And you'll pop it and if there's an abscess there, you'll find it. So
Then what do we do?
then you go on. And if you can find it, like so that the picture you showed, you have a pretty wide opening, and sometimes that's what you have to do. But a lot of times you get into that space, you pop in there, take a clamp, spread it, break open the anacoccygeal ligament, and if you can see on the inside, if you can find that internal opening and get a ceton into that space, then you can put your counter drainage, and you don't have to open them up quite as much. But you might not be able to, accepting that you might not be able to find it, but some, at least I've had at least one find it.
Yeah, but as Dr. Pickman said, keep in mind, everything's inflamed. Don't create a visual tract where you think there should be one.
It's perfectly okay though to, on endoscopy, or trachoscopy, when you're looking in, if you cannot find the opening, you just stop that and make sure it's drained and walk away, and then
A lot of times
get your,
Yeah, we never found the post-arch opening on this one. We widely drained. He improved hemodynamically. We eventually improved him. I guess he was seen in clinic at the VA yesterday, and he was not ill. It was awesome.
You look slowly.
So what are your plans for endoscopy?
I don't have to answer questions.
Who saw him yesterday? I saw him.
I did.
What's our plan?
So he still has the Penrose drain in place, and the tract is still fairly large, so we're kind of continuing to kind of monitor that. And then, as far as the endoscopy goes,
Yields, Penroses are out. Official.
I guess the question is his continence going to be?
Did he have sphincter tone yesterday?
We did not do I didn't do a digital exam on him yesterday. I just sort of examined the abscess, but that will be good to do.
Is he getting any rehab or stars and cables or anything?
So the tough thing is that it may be worthwhile thinking, and I'm guilty of this too, is when you see the patients for the first time, you're about to do some anal rectal procedure, especially something that might involve the sphincters, it's worth asking them the question of the baseline. continence and function, just so you have that documented, right? If you think about it, like you do the procedure and then they say, well, I was totally fine afterwards and now I'm totally incontinent because of you, you know, that could be an issue. But the other issue is that a lot of times, unfortunately, once you're diverted, the anorectal manometry, pelvic PT, biofeedback, all of those are not as effective. And so to a certain extent, you can try to rehab them. I'd say men, it's also harder to get them to go to those things and actually participate in it. But sometimes you kind of have to take your best guess and then decide if you're going to reverse them or not, and then take your chances.
His features were threatening enough that I think he would mandate manometry and male.
But it's
but
hard.
Again, it's not a reliable test. I mean, it's not 100% predictive. I mean, you can say, yeah, your pressures look great, we reverse you, and he's still going to be incontinent, or the other way around. Whereas pressures are horrible when you reverse him, he's fine. So at some point, you just have to use your judgment as to what the exam is like, and only one would find out.
So what's your first view take the ostomy and
You know, put it back.
what's your
or like Lee was saying, once they're pooping normally again, then the biofeedback and all that stuff is much more.
So you wait like 3 months or something.
Yes. I mean, just till everything's healed and he's always doing okay.
Yeah, when we talked to this guy yesterday, his abscess really hasn't healed up yet. We gotta make sure he's not gonna develop a fistula. Those things will all be cleared up before we consider taking down his colostomy. But if it looks good and he's got good squeeze on the finger exam, I was actually coming to Dr. Contagion about this Monday because he does the manometry. You know, a lot of that stuff you can get from history and physical exams and manometries and all that helpful. This may be one of those guys. Let's see how he's doing in a couple of months, and he wants his colostomy down. We'll see how it works. Put him through a rehab after that. I think that's probably the plan.
If you did like a diverting loop, maybe this is stupid, but could you do like anaerograde flushes through the distal end and see if they can hold it?
And you can also do enemas through a completely transected colon too. It's, yes is your answer, but you can also do it with a Hartman procedure. Even if you have a blind stump, you can have them do enemas.
Oh, and see if they can hold it.
Practice, yeah.
Wouldn't that be the best way to see if they have fun?
It's hard to predict, and I think the reality is the patients, there's very, very few patients who I've seen in that situation are that motivated to practice this and actually do it to themselves. I've had maybe like 1 or 2 in the last couple of years that are willing to give themselves enema in anticipation of a ileostomy or ostomy reversal to kind of strengthen that, especially if they've been diverted for a while.
Yeah, nobody's ever excited.
No. I mean, the other thing is, remember, if he's incontinent afterwards and you take down the colostomy, you don't have to jump straight back to an ostomy if that's the issue, right? So there are other interventions that you can use for patients who have fecal incontinence that may or may not help depending on their certain qualifications, right? SNS, we were talking about bulking agents may or may not be back now. The artificial fingers are off the market, but they were an option at one point. So most of the time we're sending people back for SNS, which is not a bad, at least trial, it's reversible. So. Sacral nerve stimulators. Yeah. So if they have 2 bouts of fecal incontinence a week or more, they can be able, and they're otherwise decent surgical candidates and haven't had sacral surgery or like that. They can have a good urology kind of access place.
Okay. Good stuff. All right. So we have 5 minutes left.
Oh.
I don't know. Do what you think is most interesting.
No, I just
So
All right, so as a really brief introduction, since we're short on time, this is an elderly lady who was initially sent to me as a hiatal hernia consult in clinic after she had been seen in an ER and had a CT scan that demonstrated hiatal hernia. Her symptom was mostly vomiting, which was actually acute on chronic. She's kind of a complicated lady that hopefully can learn something quickly.
Okay, I'll just go through her HPI since we're short on time. So she had an open banded gastric bypass in the 80s, and that's what we knew about her when she came to clinic. She also had a pain pump that was on chronic narcotics for back pain. She had reported 1.5 years of progressive inability to tolerate PO, specifically solids. She had vomiting and dysphagia. It was also progressive. I think initially when she came to see it, she would complain of dysphagia, and then started vomiting what looked like undigested food. She'd also had some respiratory symptoms and been diagnosed with pneumonia, got steroids, and occasionally took NSAIDs, even though we found out she had a GJ anastomosis, and she'd been experiencing weight loss. So these are the most common procedures that we do currently for weight loss, and these are restrictive by and large, but they also have other physiologic effects. So on the right is a Roux-en-Y gastric bypass, and the biliopancreatic limb is known as your afferent limb, and that drains your, your common bile duct in the pancreas from your, and also your remnant stomach. And then you create a pouch and bring up your roux limb to usually an end-to-end anastomosis there. And then on the right is a sleeve gastrectomy. She had a vertical banded bypass with anatomy similar to the left side. These are procedures that are not done anymore. I actually did find that diagram was kind of so I'll bring it up. So this is what her surgeon sent. And she has, you can see here what looks like Roux-en-Y anatomy, but she actually has a band around her pouch, which is somewhat long and vertical, and then a stapled anastomosis on the side, as well as this GJ that comes down. So it's like a side GJ, which is different than what we usually do.
The anastomosis was actually just to the bottom, but that's, so it was like on the side. So
below the ring.
Below the band, yeah. But that's part of the fun of these insertions.
So I'm going to put differential diagnosis here. So especially if they have dysphagia, you do want to do an upper endoscopy to rule out cancer in these patients.
You also want to do an upper endoscopy to figure out what's going on.
Their anatomy, so she had a CT abdomen and pelvis from the outside hospital, which showed a moderate-sized hiatal hernia. And then they commented on this possible window for a G-tube, which I don't know if that was a question that we had.
That was my comment, because we're thinking about treatment options for this lady who's like 73.
She had an esophagram that also confirmed a hiatal hernia. It didn't show any evidence of GERD, and she had normal motility, so we did not get manometry on her. Upper endoscopy showed a dilated lower third of the esophagus and gastritis. She did have a patent pouch that was also dilated, but intact staple line, and then the band at the bottom was tight. The hiatal hernia was measured at 4 centimeters, and then her gastroduodenal anastomosis had mild stenosis that was dilated.
So just to pause for, you can go ahead. Okay. Sorry.
So what do you, does somebody want to interpret this scan for me? I sort of gave it away. No. So you can see, I like looking at the coronals for hiatal hernias because you can often see the stomach up in the chest. It looks like her, her GE junction and her stomach is in the chest, which would be what type of hernia? Emily?
Type 1 or sliding. Is it a sliding?
No,
It could be a type 1.
Yeah, that's true. We can have both.
Or it could likely be a type 3, which is a combo.
Yes.
Yeah.
Very good. Okay. And so here are her pictures on endoscopy, and this is around her GJ anastomosis, which was dilated with a balloon dilator. You can see a picture below, and that's her post-dilation. It wasn't significantly strictured there. It was dilated up to about 2 centimeters, which is ample space. Yes.
The question there, is that her GJ anastomosis or is that the indentation?
The band was seen above this. Yeah. There was an indentation from the band.
Right. So is I'm a little unclear then, is her regurgitation due to the fact that she's got a stenosis of the gastric outlet?
Right. So this was sort of the things that we discussed in bringing her back to the operating room. Were her symptoms mostly from her paraesophageal hernia, or was it that her band was too tight?
So she had three points of constriction. So she had like 3 different reasons to have accommodated dysphagia. One of them was at the diaphragm, one of them was the band, which I don't think is shown here. And then a third one, which seemed less convincing but is the most treatable, is the GJ. Or the most easily treated.
So, in some of the decision making, we discussed intraoperatively. So we proceeded with a laparoscopic paraesophageal hernia repair after about an hour or so of lysis of adhesions for her. She had had an open vertical banded gastroplasty, so we opted to go into Palmer's point. We did our mediastinal dissection and then dissected off the sac, reduced her esophagus back into the abdomen, and then reconstructed her hiatus with silk sutures. We did a toupee fundoplication. You guys know why we do?
Yeah, how can you do toupee?
Oh, on her, yeah. But in general, we do a toupee fundoplication. You guys know why?
But not in somebody with a previous bypass.
Correct.
Yeah.
If this was just if this was a primary paraesophageal hernia. So the dissection that you do, you end up taking down the frontoesophageal ligament, which is primarily used in keeping your esophagus, below in your abdomen, and responsible for sort of the reflex you get while swallowing. So the longitudinal muscle of your esophagus contracts, and you actually do get some physiologic herniation of your GE junction when you swallow, but you basically destroy this mechanism when you do your dissection. And so this is to prevent reflux and also helps keep your repair inside of your abdomen.
So to be clear though, why can't you do that anatomically in this patient?
She doesn't really have a fundus for that.
Attached. Yeah, so something that is hardly described is people take the rodent stomach and create a fundoplication. That doesn't end well. So one should not be fundoing people who have gastrogenic monsters.
Will you pass through that pouch though?
So what did we, do you remember?
I think we just plicated it.
Yeah, we ended up actually pexing her esophagus, which gives me angina. That's what we did. We closed the diaphragm and then we pexed it. There wasn't much room to pexy her pouch. But I guess the big point here was deciding between actually revising her banded bypass versus just doing the paraesophageal hernia repair. And I elected to do the paraesophageal hernia repair only because of the higher risk profile of completing the entire operation in this elderly woman, and also because her history of symptoms was more short-term, and she had had her original operation 30 years ago. That doesn't necessarily mean anything because it can take a long time for patients to develop symptoms from this restriction. So we'll see how she does.
So
My question was with her age, should we, what's the benefit of operating on her versus her morbidity?
But then revising her bypass and making a new GJ is also doable but higher risk.
Absolutely.
To devil's advocate though, like how long was your basis of lesions?
An hour.
In gastroplasty is 72. And so if she stenosis further, do you not then have a gastric outlet obstruction below your perisophageal hernia in an older patient? And now it's having third operation.
That sounds like a Dr. Eibel's question.
Well, it's all of our special. We're all needed.
Patients come to you all the time, right?
Yeah, and we have these discussions in our educations conference. But, why not? We do the gastro J and take out the PhD.
So we looked at that and thought about it, even thought about actually dissecting her band off of her stomach and removing that.
Really hurt.
Yeah, it was so scarred. Yeah, and I think we thought just due to the chronicity of her symptoms, the fact that she didn't have, acute symptoms, that this was sort of insidious over a year and a half, that we would use the thing that was easiest first and see how this resolves her symptoms.
I'm not sure that her lysis of adhesions will be harder. I think it would be easier if we had to go back because we've already done it and we did a laparoscopic operation. This operation took 2 hours, so it wasn't, I don't know, it was an intermediate length operation. So I had also had a few preoperative discussions with her. I don't think it's like answer. It's hard to know what was most contributing to her symptoms, but initially we were thinking about not operating on it at all, and it took a long time for her to be interested in having any operation, so I was interested in minimizing risk because initially we were actually just planning on doing G2.
Did she feel better with the gastroenterology?
It could still be related to the band, I think. But yeah.
These are hard because unlike lap bands, which you guys are thinking about, the GI people will write in their notes incidentally like BBG and lap band, and it means the same thing to them, and they're very different. And one is much gnarlier. So the vertical banded gastroplasty, they would take like a mesh band, and the stomach grows into it, and it's not like it's just sitting on the stomach there for you to see and pull off. It's embedded in the gastric wall, so it's not an easy thing to just pull out the band.
So Elizabeth, 6 months from now, she comes back has the same symptoms. What do you do?
I would scope her and look at her band and her GJ.
GJ looks fine. Band looks the same.
I think you go through your workup algorithm again, and she doesn't cover a current hiatal.
Let's go back. What would you do?
Oh, yeah, so I would get a CT scan to start out.
Looks, her stomach is interacting.
Okay. And then I would repeat her endoscopy.
Looks the same as it did at the completion of the last endoscopy. You get it. We've been throwing an upper GI, and it looks like she's got a little hang up around her band. That has the same symptoms.
Yeah, and that's a good point. I actually think the upper GI was one of her most valuable preoperative tests because it showed pretty significant hiatal hernia, and she actually passed a tablet.
Yes.
Yeah, through her band, a 13mm tablet. So I think that's probably the most helpful pre-op. Hopefully.
So what are you gonna do?
Yeah, what about Dan's scenario now?
I think you look at her comorbidities and her nutrition status, and
They haven't changed. Only 6 months later.
hopefully her albumin's better.
No, it's not.
It's not, it's worse. Okay.
No, it's not worse. But so you fixed the hiatal hernia, and she had short-term resolution of her symptoms, but her symptoms have now come back.
So you haven't had this yet in the teaching conference. What's another often missed discussion of bariatrics thing to evaluate dysphagia and regurgitation?
You can do manometry. Yeah.
So internationally about the patient
Now what? So these are realistic board scenarios where you're not going to necessarily, the idea here is to test judgment and not test knowledge. So what sort of judgment are we trying to test with this by asking you this? Right. That's exactly right.
And the answer is not always yes. Some advice, it's okay to say no.
And that's the point that I was getting at with this is you don't have something anatomic or a finding that you're going to correct. So what are you going to do with surgery to try and make her better? And you don't have a target to go after.
Well, to be fair, she will always have something anatomic, right? Because she has her surgical history. But it's just a question of risk benefit in this person, you know. And there are definitely elderly patients who can do well with this revisional surgery, so it's not necessarily ruled out. But it would be the same risk benefit discussion with her of sort of alternate feeding access versus revision.
But like with forehead, especially that I personally have a harder time with, you have to have reality checks occasionally. It's just, you're trying to do a lifestyle operation, and you know there's good and there's perfect. But you may, you know, have somebody with a lifestyle problem, and you go in and you create a hole in these outcomes. And now they're, you know, on a team too, and they're in the ICU with stenitis, and now their lifestyle is very bad. So you kind of have to, you know, factor that in. Just like here's an anatomy problem, it's not perfect.
And actually, another thing that we haven't talked about in this case, but that we should always consider is psychological comorbidities. And you know, her daughter actually came to one of her appointments and pointed out that she has a lot of food aversions and that her eating may never be normal, regardless of her anatomy, and was favoring sort of less invasive interventions. And so this lady has not actually had a psychological evaluation, and maybe she should have a preparation for this operation, but if we were considering that probably would be a good idea.
And in general, for these patients, you could try non-surgical treatment first. Whether it's
Are we right over?
That's good to take 5 minutes. We have questions. Josh and Barry,
But you wouldn't have been part of that
I'm just sitting there
It's one of those ones that is